Very good afternoon to everyone. I'd like to thank Dr. Aditi, Dr. Sneha, and the whole AIS team for including me in this wonderful session, this indulging session. So I'd like to show a video of AGV implantation. This is the case where repeat trabeculectomy was done. These are the previous two trabeculectomies was done, and what all challenges I faced during the AGV tube implantation that I will be showing here. So I have like fast forwarded a part where it was not necessary. I will show the important parts only. It is edited video. So first of all, I check the like whether the conjunctiva is mobile or not. Then I may make a peritomy at around 2 mm from the limbus, 2 to 3 mm from the limbus. I'd like to know the expert's opinion regarding this also, because there are two schools of thought. One in the making the incision at limbus, and 1 2 to 3 mm away from the limbus, which serves them better. So I made a incision around 2 to 3 mm away from the limbus. Then the first problem I faced during the AGV implantation is this anchorage suture. You can see there are two tabs here. There is a dearth of space actually. So when I am doing this, passing this thread, I had a problem for visualization. So I took a muscle hook and I asked my secretary to grasp it and retract the conjunctiva. Then only I got a good view, and then only I started the suturing. So what they are taught and what they do in this sort of kind of scenarios where the eye is crowded and there is not much space, I would like to know that. Then after the cutting the tube, the main step comes to insert the tube in the anterior chamber. So the textbook teaches us there should be a sharp entry around 2 to 2.5 mm behind the limbus through a 23 gauge needle. I did that. But what happens is when I grasped the tube and I was trying to push it, it was not going in. I struggled, I pushed it here, but it was not going in. Then again, I came out and I tried again. It was not going in then also. Then I came again out again. I tried again and again. And now this time it was going into the sulcus. I made a false entry. It's not visible here, but actually the iris was tenting up. So I went to sulcus. There was a chance of lens injury also. So I got a little scared. I went and like enlarged the needle track. And I know this is a controversial. I should not have done that. But for the entry of tube, I had to do that, and I inserted a tube. Now this has gone nicely. So what they are taught regarding this step, and after that, like we know, we have to stop the tube erosion through the conjunctiva. So you have to place a graft. Before the corona period, we used to use the corneal graft for this AGV to graft the tube. But now when the cornea is not available, we use the sclera, and it is very thick and tough structure. You can see that I am struggling actually to pass the needle, and I have to pass it through 4 places, like to anchor it in 4 places. So it's a very difficult thing to anchor the sclera. So if the expert panel can tell like whether what else I could have done, like other than using the sclera for this thing, that would have been beneficial. So I have done the scleral patch graft over the tube. And the last problem what I faced during the AGV surgery is the conjunctival retraction. Previously, before I used to have a continuous suture all along this section, but it used to gape because of the conjunctival retraction. So what I started to doing is 2 interrupted suture, and then continue the rest with the continuous suture. And I generally give doxycycline at the end. I would like the expert panel's comment regarding that also. Thanks a lot.
Thank you, Kamunash. So in the panel for glaucoma discussion, we have Dr. Kumar Ravi, sir. He is the consultant glaucoma services at BBI Foundation, VIP and Netralayam, Kolkata. He has multiple publications to his credit. So, sir, over to you.
Thank you, Sneha, and thank you, Aditi, for having me in the team. And thank you, AIOS, for giving me this opportunity. Dr. Tamunash, excellent surgery, first of all. There is hardly anything to add from my side because this kind of trivial struggles all of us have at one time or the other. Just to add a few things here and there, usually I make my conjunctival incision exactly around 4 to 5 millimeter away from the limbus. The advantage that I get is that it is equidistant from the anterior entry and the posterior side, wherein we have to suture the valve, body of the valve with the sclera. So the exposure is quite good if we are 4 millimeters away. Another advantage is that when we close it by the suturing, the next morning the patient is comfortable, because if we have sutures at the limbus, the patient is uncomfortable, watering is more. And if it is little away, then usually the discomfort is less. This is the first point. Second point is while starting the surgery, I usually take two fixing sutures. One is cordial fixing suture and one is superior rectus. And for cordial fixing suture, I was seeing that when you're doing surgery, the eye was continuously moving. Maybe it was not fixed properly. So with the movement of the patient's body or head, there was some kind of movement which was creating trouble when we were putting the body of the valve inside the conjunctival pocket. So what I do usually is I ask for 2 assistants, and 1 assistant is there to hold this corneal traction suture all the time, especially when I'm putting the valve and suturing the valve with the underlying sclera. At that particular time, I ask for 2 assistants. Coming to the entry point, what I saw is we were entering little diagonally. There must have been some reason for that, but how I make my entry is with a 24 gauge needle. I make straight stab incision kind of incision, just like we do while making a side port. The advantage that I get with that is that the track is very small. The entry of the AGV tube is exactly at the desired angle and the way you want it to go. That is number 1. And then I use a special instrument which comes with the same company which manufactures this device, which gives a good grip over the tip of the instrument. One more extra thing which I do is I go with bevel down approach. If just imagine when you're rotating the tube bevel down, then the tip of the AGV cut tube is in the upper part. So even if it goes and hits or goes very close to the iris, then now the natural tendency of the tube is to, just climb over and go into the anterior chamber. If the bevel is down, then it tends to penetrate into the iris and go into the sulcus, which some of many of us face. So if we keep bevel down, then usually we enter directly into the anterior chamber. And coming to the points that you've discussed now, like regarding if there's a difficulty in suturing, we can also consider hang back technique, wherein we don't suture the valve, we just put the sutures to the AGV tube and hope that it stays there. That is one thing. Second thing is what I have modified in my technique of AGV is while I'm putting the scleral patch graft, I put the scleral patch graft, the rectangular part, if you see, the breadth one, the one which is wider, that I put facing the limbus. Okay, so that covers the tube well, and the chances of mobility of that scleral patch graft is less. So that gives a good cover to the tube, and we hope that it will not expose the tube in future, even if it is little bit moves here and there. And with this technique, I have been able to reduce the number of fixating sutures to only 2. This I pre-place beforehand, like before doing the surgery only, I keep my scleral patch graft ready with 2 fixed sutures. So a large graft, put it over the tube, one fixating suture on one side and other on the other side. And if I have availability of glue, then I use glue. I sometimes totally avoid the use of sutures, because sutures, yes, it sometimes messes up the surgery. So if it is available, well and good, go and just use a glue. And even if we have access to glue sometimes, then you can even close the conjunctiva with the help of glue. Yes, there's a cost factor involved, but there's a cost factor involved, but if the patient can afford it, the comfort that you get in the post-op period is just excellent. You will have, the post-op outlook is something similar to, I would say, a topical phaco surgery rather than an SICS kind of a surgery. But then if it is not available, 2 sutures for fixating, that suffices. And I think the surgery was well done, so there's very little to add, just a few heat tips here and there.
Thank you so much, sir. We would also like a quick comment from Dr. Manda Paranjpe, sir. So, sir, we know that in glaucoma fellowships, the exposure to valve surgeries are not so much. So, any tips that you would like to give to our youngsters who are going to start with valve surgeries for the first time? And what is the difference in starting with the AGV and the ADI implant?
Thank you very much. I personally don't have any experience of ADI implant, but valve surgeries themselves are a tricky business. So, as with any other surgery, one has to have a good mentor standing by you for performing a successful surgery. You have to keep in mind all the steps which have been very beautifully elucidated by both the earlier speakers while doing this kind of surgery, and particularly specifically in this particular surgery, in which 2 trabs had failed. So we have this conjunctival scarring as an important factor, which can complicate or make things difficult. So you have to keep that in mind as well. So while training for any surgery, one has to have a good mentor who can guide you in performing the surgery. Stick to the basics. Don't try to be too experimental in performing these surgeries. And keep in mind the complicating factors that you are dealing with. So pre-op analysis and pre-op discussion with your seniors probably will help in giving good outcomes.
Thank you so much for that enlightening discussion.